Hello, welcome to Module 1. This is Heather Sloan, and I am a nurse practitioner here at Meadowlark Hills. This is a topic that is a particular interest of mine. Through my career, I've primarily focused on neurology and the care of ICU patients. So hopefully some of that experience I can hand on to you to help increase your knowledge base as well. Just a bit of a disclaimer with the presentation. I've presented a few times and it is very heavy content. It's content that's difficult to talk about on a day-to-day basis, but our overall goal for you is that by working through this content that you will gain a better understanding and knowledge base of caring for those with dementia, as well as the disease process, what's currently being done to treat the disease process, and where research is headed as well. With slide 1 here, we're talking about essentially what dementia is, the causes and the symptoms that are frequently noticed with this disease process. As you look at the photo that's listed there on the slide, the picture really depicts the pathophysiology and just is a bit sobering to see how things change with this disease progression. On the left side, you'll see a normal brain, and then on the right side, you see a diseased brain. And really, what happens is as these different pathophysiological processes play down, the brain does actually atrophy and shrink, which helps explain a lot of the progression of symptoms and just depending on where that damage is occurring, why certain symptoms may persist. So, what is dementia? Dementia is essentially a mental decline in one of the 4 core areas pertaining primarily to recent memory, language, visual spatial, or executive functioning. The causes are specific on the type of dementia process that's at play, but essentially it's damage to the brain cells based on the type of dementia, which we'll get into on a later slide. Symptoms consist of memory trouble that disrupts daily life, problem solving, planning, difficulty completing tasks, time and space confusion, conversation concerns, and misplacing objects, poor judgment, withdrawal from social or work activities, and mood or personality changes. The severity of these symptoms are going to depend on the staging of the disease process as well. Dementia is used as a term that's really an umbrella term that encompasses several different disease processes. With this presentation, really, we're going to limit it to the 4 primary types of dementia. And on this slide, you can see essentially the frequency of each one of those 4 types. The first is Alzheimer's, which is the most prevalent. It's seen in approximately 50 to 75% of patients. Vascular dementia is the second most common, and that's seen in about 20 to 30%. Lewy body is the third, and you see that in approximately 25 to 10% of patients. And frontotemporal dementia is the fourth variety. This slide moves into breaking down what actually is happening on a pathophysiology type level with the 4 key varieties of dementia processes. And essentially, in a nutshell, what's happening is there's some form of breakdown in the brain, whether it's a roadblock because of plaques and tangles or some sort of a protein deposit that ultimately inhibits how well the neurological impulses are moving down those fibers of the neurological tissue in the cells. So Alzheimer's is essentially a formation of plaques and tangles that are protein deposits by beta amyloid that cause twisted fibers and just essentially a breakdown of the communication between the brain cells. Vascular type dementia processes are going to be the result of hypoxic type injuries such as strokes, or different cardiovascular disease processes that form plaque in the heart vessels and restrict blood flow And ultimately, vascular-based dementia processes are the result of oxygen deprivation and nutrients to the neurological tissue. Um, Lewy body is another form of dementia that occurs as the result of abnormal alpha synuclein protein deposits, which is the key protein in this specific cell, the Lewy body cell. Something that's particularly unique to this type of dementia is the occurrence of hallucinations, delusions, and this is also the predominant form of dementia that occurs with Parkinson's disease. Moving on into the fourth type, frontotemporal dementia processes primarily refers to the location of the damage. And the significance about this is that the frontal region of the brain is going to control a lot of impulse control as well as personality. And so oftentimes the symptoms that emerge with this process are quite distressing for patients, for caregivers, and can lead to different varieties of aggressive behaviors or problematic behaviors for the caregivers that are taking care of these individuals. It's linked to tau protein and the TDP43 proteins. Particularly, this type of dementia is an earlier onset, around age 40 to 60, with a third of these cases being genetically based, and two-thirds, or the majority of these cases, the cause is never really known. So why are these changes problematic? Again, I'm someone who's very much a visual person, and I think this slide really shows you that. It compares healthy brain tissue and healthy neurons to diseased brain tissue and diseased neurons, and what physically happens to the brain. So in the top left-hand corner, you're going to see the healthy brain tissue with the healthy neurons. And below that, you see Alzheimer's type presentation of a brain that's diseased. And again, how those typical highways of communication with the neuron are disrupted due to protein formation and just essentially damage to the brain tissue. In the middle there, again, you see the atrophy that takes place or how the brain physically shrinks with the disease progression. And the picture there on the far right does depict some of the key areas that are affected. When you think about brain tissue, location is really significant because the area of location where the damage happens directly will relate with the type of behaviors or symptoms that you'll see. So, for instance, if someone's language or parietal region is impacted, then you may see different concerns with communication, with instruction, with being able to complete, a direction, those sorts of things, as well as, like we talked about with the frontotemporal dementia, personality, which is in that red area. Intelligence, judgment, and behavior are also encompassed in that. So, how big of a problem is dementia? I would say that currently it's a big one, and it's only going to grow in the coming years. So we are hitting the baby boomer generation in internal medicine, and that means that because there's a larger group of individuals in this age range, the prevalence is going to rise, and we're going to see more of this, which does further stress the healthcare system. It stresses caregivers, and it also creates a rising demand for care and new breakthroughs in management of the disease processes. So just the stats, you can review those there on the right. 1 in 10 by the age of 65 will have dementia. The prevalence increases as the years go on to 1 in 3 after the age of 85. It is the sixth leading cause of death, and the prevalence of Alzheimer's doubles approximately every 5 years after the age of 65. The cost of care is around $230 billion and rising currently. The picture there on the left does depict that the world statistic as far as dementia by 2050 is estimated to be 131.5 million individuals, as compared to a more recent statistic in 2015 at 46.8 million individuals. This slide is another easy way to show the prevalence and just the significance of this problem. Again, it shows the 131.5 million individuals that are going to be estimated to have dementia by 2050. And 68% of this is going to occur in low and middle income countries. Approximately every 3 seconds, an individual is diagnosed with dementia. So, pretty startling statistics. This slide shows, in a nutshell, the different stages of dementia and the disease progression. It really breaks down into approximately 3 stages: early, which is also considered mild, middle or moderate, and late or severe. In early dementia, the symptoms are mild. Most of these individuals can function well in daily life. Some of these individuals are working. They may drive, they may engage socially. Typically, only the close friends or family are noticing symptoms at this point. They might forget familiar words, locations, everyday objects, and just experience just undertones of memory loss or memory lapses at this point. As the disease progresses, you enter into the middle or moderate phase, which is the longest and typically the most distressing phase. The reason why it's the most distressing is that the person is aware of their impairment and that they're not able to accommodate well or function like they used to, which is distressing, as you might imagine. Family members, acquaintances, more people are starting to notice this, and it is a source of anxiety for a lot of folks. The symptoms ultimately are just more readily noticeable. Oftentimes, the degree of impairment also means that that person is going to face life transitions, such as a move to a different location with added nursing support or medical support, or need to look towards their loved ones for just added support and care. The late or severe phase is when symptoms are quite pronounced. Um, this sort of disease process means that the person is dependent on others for care and safety. They gradually lose their ability to respond to their environment, carry on conversations. And this is also where the personality changes and the mood disturbances do become most severe. Sundowning is a special topic that we talk about in dementia patients. And essentially, it's a special behavior phenomenon that occurs with demented individuals. It's typically a period of increased anxiety and restlessness that occurs particularly around the time of sundown or in the evening hours. The thought is that potentially it's related to fatigue from the day or just overstimulation as the driving force of these behaviors. And to review the slide there, it just defines exactly what it is, that it's a nighttime restlessness and agitation that occurs in dementia patients. The symptoms typically consist of restlessness, worsened confusion, difficulty sleeping, delusions, aggressive behavior, and the elopement risk or the risk of the person trying to leave their environment increases. The etiology, again, we touched on was that it's most prevalent in the evening hours, and it does seem to occur with a higher frequency of folks in the middle stages of dementia. Management is typically supportive, so remaining calm is huge, as well as increasing daytime activity to try to wear the person out. And increased nighttime lighting is a unique recommendation that they say. The thought there is that the increased nighttime lighting is going to help decrease the person's unfamiliar approach to the environment. So with decreased lighting, things do become darker. Vision may not be as acute as it once was, and it promotes confusion and dim lighting. So they have found that increasing a person's lighting will help manage these symptoms as well. You also want to adhere to a daily schedule and avoid overstimulation. So it's a bit of a fine balance trying to wear the person out enough that they will rest, but not overstimulating to the point of over fatigue, which would also drive some of these symptoms. So that last video that you viewed showed the lived experience of working with someone with dementia, and particularly with an individual who's experiencing sundowning. It also showed a glimpse into positive approaches and negative approaches for caregivers. As you can tell, again, the symptoms do tend to be fairly distressing for loved ones and for the individual experiencing them. But as that last slide before the video depicted, it shows you just a few ideas on different ways to help manage those symptoms as well. As a caregiver, really the biggest piece of advice that I would give folks going through this process would be to meet that person where they are. Much as if, someone had been working with you or I, and they tried to tell us that our reality was not accurate, that we weren't really in Manhattan, Kansas in the month of July, we would probably become aggressive and want to argue with that person. The same is true for folks that are going through a dementia process. They believe their reality to be true, and really, with caregiving, you need to meet them where they are and try to help sort through whatever the distressing factor is for them in their world. This next slide here that you're looking at does breach into current treatment options. And really, currently, most of the medications that are on the market honestly don't work very well. The goal of these medications was primarily aimed to slow disease progression, maybe improve memory slightly at the time. But the more and more that we use these medications, the more it becomes pretty obvious that they just don't get the job done. So at that point, what happens is supportive care is the focus of care. We want to work to preserve quality of life, to preserve integrity of that individual, preserve dignity, and preserve safety. The medications that are listed there, particularly Aricept and Namenda, those are some of the standard dementia medications, if you will, that you do see a lot of folks being started on and being continued on. But again, they just don't really seem to help a whole lot. Most of the population we work with down in special care with, real advanced disease progression, we end up having to add in additional drug options to help support them. Things such as antidepressants, antipsychotics, and at times anti-anxiety agents. Really, the overall goal of these medications are to preserve safety and quality of life. So safety pertains to both the patient and those that are within their environment. Sometimes patients will become quite aggressive to staff or to other residents, and that typically is a driving factor in the start of some of these medications to reduce risks to the patient and to others that are in their environment. But the bedside supportive care cannot go mentioned enough. Really, the caregivers that are at the bedside are working to triage through the different challenges that arise on a day-to-day basis. And really, it boils down again to meeting that individual where they are. Try to figure out what the problem is and correct any factors in the environment, or provide different forms of soothing that person or decrease in stimulation at the bedside to help improve their overall mood and their distress. One thing that's become of particularly interest here at Meadowlark that we see our special care units using a fair amount of the time is music therapy. So this is where management does start to breach over into some alternative forms of healthcare, things like music therapy, aromatherapy, just different ways of trying to relax that individual, trying to supplement in different activities that may be soothing or just provide them a lot of relief. So on this next slide to come, it's going to play a song that's probably familiar to most of us. And it really just asks you to enter into how music therapy may be beneficial. So I'd encourage you to sit back, listen to it, close your eyes, think about the lived experience, where this music takes you, and what it might bring to your mind and how it might affect you on an emotional level. So that music may have taken you to, a snowball fight or a special event with your parents or a music rehearsal. It's different for each one of us, but that is just an example of how various alternative therapies are beneficial for both folks that have dementia and for us on a day-to-day basis. This picture just again prompts some of the different things that they're using in special care to help manage the symptoms and to help bring quality of life to these individuals. Um, the top corner shows a picture of a woman gardening, which may have been previously a hobby that was a passion of hers. It's quite interesting when you walk onto a special care unit that potentially you'll look around the room and see various realities taking place at any given moment. You might see a person petting a fake cat, or another person cradling a doll, or someone folding washcloths. And really, what these different interventions are doing is they're taking that individual back to something that they may remember in their long term memory that was a day to day occurrence and gave their life purpose. And these are different measures that do help bring quality of life and, again, just soothing properties. When currently we face, from a medical side of things with drug medications, just not a lot of success. This next slide shows, uh, in my mind, 4 key areas of supportive care, and specifically examples on how those different key areas are implemented on a day-to-day basis. So in the top left-hand corner, you see personal. So it is really important when you're working with these patients to understand their personality, understand their life history, particularly preferences. So all of us have a different story, and that story does matter when we reach this phase of life. So particularly, there may be something that used to irritate this person, or a past traumatic experience that will emerge as this disease progresses. So understanding that person's social history, their needs for personal space, and their family structures or dynamics will help assist with quality of life and just with management and understanding what makes that person tick and how to better help them during times of distress. The environment is also important. So we did mention lighting needs earlier. Sometimes low light is a good thing, and sometimes low light is a bad thing. Music therapy, which we just experienced, potentially aromatherapy has found some benefit. Temperature needs. So you might imagine how cranky you might get if you're cold or if you're hot. And then just familiarity of surroundings and continuity of their surroundings is also soothing. And then if we cycle down to physical and emotional needs, just making sure the basics are met, that that person is not hungry, that they're not needing to use the restroom, that they're not in pain, overly tired. Their need for touch, exercise needs also play into this. So again, just boiling down to the basics, understanding that person and making sure that basic needs are met. And then when all of these things are at play and we're still having trouble, sometimes plain old distraction is helpful. Engaging in conversation with the person. Kits may be helpful. So that again cycles back to things that may have been helpful previously in that person's lifetime. So potentially if they had worked doing cleaning tasks at home or raising children, trying to create a kit that simulates some of these things, such as a gardening kit or a baby doll to hold, or potentially even petting a fake animal may be helpful. Physical activity is an effective form of distraction, and it does tend to just wear off energy as well. And again, entering into their world, understanding what's distressing them at that time, in their reality and finding a way to help them through that. This next slide, in a nutshell, tries to capture some of the new advances and goals of research. So there's different forms of ways to intervene with a disease process. On the right-hand side, you see that depicted pictorially. So primary prevention is going to be the hope of delaying onset of the disease process altogether, so to prevent the tangles and plaques from ever forming. Goals of secondary prevention are going to be focused on delaying the onset of cognitive impairment in individuals with evidence of pathology already occurring. So we're wanting to just prevent it from getting worse, essentially. Tertiary prevention overlaps with that a bit and also focuses on essentially delaying the onset or the progression of the disease process as well. So there's different ways to do this. They're finding more and more that basic healthy lifestyle is key to care. So making sure that individuals are living throughout their lifetime a healthy lifestyle, that we're exercising, we're adhering to a healthy diet, we're taking time for sleep and stress management. Then you also want to focus in on controlling risk factors. This really is most observed with vascular types of dementia. So making sure that we're managing comorbid conditions, things like diabetes, high cholesterol, high blood pressure, things that affect our vascular system and do promote an environment for things such as stroke or a heart attack, which ultimately do impact the brain as well. Medications. Part of the limitation to where research can move with medication development is the existence of this thing called the blood-brain barrier. So our brain and our body is really good at keeping chemicals and various things out of our brains as a protective defense, and that's called the blood-brain barrier. Due to this, it does make it quite challenging to find medications that chemically can cross that barrier and prevent or treat things like dementia and just neurological conditions as a whole. Supplements are something that a lot of folks are interested in, but the research has not panned out with these. They've not been proven to be terribly helpful. And so really we're encouraging folks to think about enrolling in a study so that we can gain more knowledge. This next slide again is on research. So really it breaks down in a nutshell things that are helpful, healthy ways to live your life, and just basic benchmarks of things that are going to help your overall health, which also benefits your brain. So exercise is one area of focus. It is showing modest benefits in slowing progression. And how much is helpful? So on average, we typically recommend that folks think about 75 to 150 minutes per week. Up to 220 minutes has been studied, but has not necessarily been proven additionally beneficial beyond that 150-minute benchmark. Diet focuses, they're starting to find that on average the Mediterranean diet, which is focused on healthy fats and decreased carbohydrate intake, is helpful, as well as the DASH diet, which is going to be low on salt. This feeds into a bit of the comorbid conditions side of this discussion and helps to manage some of those disease processes, which in turn benefits the brain. Also, lower saturated fat has been found to be helpful. And then also just remaining engaged. Mentally engaged and socially engaged with your life and your environment has protective benefits as well. This is a list of local web pages and national web pages with various research options, ways to enroll in studies, and different things that are going on in the area and national as this field of study continues to evolve. So feel free to access these if you're interested in participating or just learning more about various forms of research. Prevention, again, this is another pictorial way of demonstrating the basics of things that are good for your overall health and good for your brain. So stay active, stay engaged, try to remain socially engaged as well. If you can, enroll in a study and participate in research. Research is not just for the folks that are experiencing a dementia process, but also for healthy individuals, so we can gain a better understanding of the differences between those that suffer from dementia and those that do not. And management of chronic diseases also will go a long way in prevention of various forms of dementia, particularly the second leading cause with vascular dementia. And then I wanted to include just a basic slide on caregivers. You'll learn more about caregivers and the special challenges they face in the modules that are to come, but this breaks down the basics of it. And it's quite sobering. Taking care of someone with one of these dementia processes is extremely exhausting and extremely challenging. And we need to take care of our caregivers so that those that face dementia are well cared for as well. Approximately 70% of caregivers of loved ones with Alzheimer's or dementia processes do meet criteria for major depression disorder. And that's something that we want to try to help those individuals with. Part of what drives some of the depressed mood is different processes such as anticipatory grief and just overall compassion fatigue. So, anticipatory grief is the feeling of loss before a death actually occurs. Dementia processes, I feel like, are the perfect example of this concept because really, caregivers and those that love the person that's proceeding through dementia are constantly facing loss. They face the loss of that person's ability to care for themselves, they face the loss of being recognized by that individual. Which takes particularly a lot of stress on loved ones because the individuals with dementia may not recognize you anymore. They may not be able to recall common experiences that you've lived through with them or remember much about you or your life together, which is very hard to cope with. So recognizing that that does exist and really allowing yourself permission to grieve through that is huge. Um, a lot of folks are challenged to want to be the caregiver as a way of taking care of their loved one and feeling like they're treating them to the best of their ability. But sometimes the demands of caregiving will also impair a relationship with that individual. So, really working to preserve the relationship should take primary role and secondary, what you can give, work on giving. And if you can't, then there does come a time and place to look into other care options. Compassion fatigue is another challenge that caregivers face. It's just essentially a state of exhaustion, physical exhaustion, emotional exhaustion, and dysfunction as a result of prolonged exposure to compassion stress. So essentially, people just wear out. And if you don't have a chance to fill your own cup up, it's hard to give to others constantly on a day-to-day basis. This is a concept that we discussed a lot at nursing school because it is inherently a role that you constantly care and give to other individuals. And there's a lot of wisdom to taking care of yourself in order to take care of others. The final slide here is just a list of resources and different things that I've accessed to create this presentation. So feel free to go out there and learn more about them with the various web pages that are listed. So thank you very much for listening and taking a special interest in dementia. It's something that's near and dear to my heart, and I hope that you've gained some additional understanding in the disease process, the management, and just the basics of caregiving. Thank you.